everyone. Thank you very much, all of you joining us here in the room and also via Zoom. My name is Mariana Lasso, and I am a faculty as a Urban Health Collaborative, and I co-lead the Community Engagement Core of the CCUH, and also part of the SALURBAL study in co-leading the capacity building core for that. And it is my pleasure to introduce our speaker of today's webinar, Dr. Nicole Errett. Dr. Errett is an associate professor of environmental and occupational health sciences at the University of Washington. She's director of the University of Washington Center for Disaster Resilient Communities, Director of Research and Implementation at UW Center for Health and Global Environment Change. Her research focuses on the development, implementation, and health impacts of policies and programs that aim to build resilience in the context of public health emergencies, disasters, and climate change. She works closely with public health practitioners, emergency managers, community-based organizations, and others to design and implement policy-relevant research that contributes to real-world solutions for facing disaster, climate, and health problems. Her research leverages qualitative and survey methods, and she frequently collaborates on interdisciplinary teams. Dr. Errett previously served as a special assistant to the Assistant Secretary of Preparedness and Response at the U.S. Department of Health and Human Services, the Policy and Legislative Director at the Baltimore City Mayor's Office of Emergency Management, and the Evaluation and Assessment Manager at Northwest Healthcare Response Network. She holds a PhD in Health and Public Policy and an MS-PH in Health Policy and a PA in Public Health Studies from Johns Hopkins University in Baltimore. That's where Nicole and I met a few years ago. And she completed a postdoctoral training in coastal community resilience at University of British Columbia School of Community and Regional Planning in Vancouver, British Columbia. So it is thank you very much again, Nicole, for joining us. I'm really looking forward to your talk. The title is Challenges and Opportunities for Extreme Heat Preparedness and Response in the U.S. Cities. And just a couple of reminders. So there's interpretation to Spanish and in Portuguese available. Click to the icon that is like a little word in your meeting controls in Zoom, and select the language that you would like to hear. And then use the QA button to submit your questions, and we will answer them at the end of the meeting. So thank you again for those of you joining, and especially Nicole, thank you very much for accepting this invitation and sharing your work with us.
Thank you so much, Mariana, and the Drexel team for having me, and for you all for being here. Let me share my screen. So I'm going to talk to you all today about a project that we had supported by the Wellcome Trust in partnership with Boston University to look at implementation of extreme heat preparedness and response in U.S. cities. And so we focused on cities for a number of different reasons, but first, because cities, as we all know, are particularly vulnerable to extreme heat events. In addition to the fact that climate change is already increasing the frequency and intensity of extreme heat events, the urban heat island effect results in urban temperatures that are 5 to 15 degrees Celsius warmer than rural and suburban areas. We also know that there's a lot of different groups of people that live in cities that all have unique vulnerabilities to heat. And cities are not a monolith. Our city, I'm based at the University of Washington in Seattle, is up in the northwest corner of the United States. And most of us in Seattle enjoy our very temperate summers that we have Typically, we don't have a lot of extreme heat events. We're known for our rain in the winter, but we do have these most beautiful summers that are very temperate. And we have been touted as a climate refuge. And I put in the corner of this screen an article from The Guardian because in June, July of 2021, we had a heat dome event, which shattered that reputation of being a climate refuge. In Portland, Oregon, there were temperatures that exceeded 117 degrees Fahrenheit or about 47.2 degrees Celsius for multiple days during this heat dome. And this resulted in a large number of impacts across the region. And my colleague and friend Joan Casey led this paper that was published in the American Journal of Public Health on the right that showed that there was an estimated 159 excess deaths in the state of Washington alone. And this affected Oregon, it affected the state of Oregon, it affected Vancouver, Canada. So a lot of more widespread impacts. This is just the tip of the iceberg. But some of the things that made this event particularly significant in the city of Seattle are things that have to do with some of our temperate climate. So we have low rates of air conditioning in the city. I moved to the Northwest from Baltimore, and I remember one of the things that was in my lease at the time when I was renting a condo said that we couldn't have an air conditioner. And I was like, I can't move into a place without an air conditioner. And the landlord assured me that because of these temperate climates, that you very, very infrequently need an air conditioner. And I just misspoke and said needed in the past tense because that really is becoming a fact of the past. We're increasingly having events that are requiring air conditioning for people to stay safe, but we haven't yet caught up with that in terms of the population and also the building capacity to take them. We also are a very seismically prone community, and so window units for air conditioners are not particularly safe, requiring large portable air conditioning units, which can take up space, be more costly. And so there's a lot of reasons for this, but this historically temperate climate has limited the rates of air conditioning. We also have in Seattle a geographically centralized healthcare system. Seattle is a big city, but is surrounded by a large number of rural areas. And so our healthcare system serves a large number of rural areas, not just for the state of Washington, but for what we refer to as the WWAMI region, which is Washington, Wyoming, Alaska, Montana, and Idaho. And so we have people coming all over the world and all over the region to receive healthcare in our city and the surrounding areas, which brings a lot of medically vulnerable people to the area. And our healthcare system, what we learned from this is that some of the infrastructure in healthcare systems is really made for the local environment. So air conditioning in the facility was not up to snuff for an event of this magnitude. And so surgical operating rooms, for example, could not be cooled to a temperature for which they were safe to operate. Because they are used to this temperate climate and they were made for this temperate climate. And so fortunately, or in this case, the event happened on the weekend where there weren't a lot of surgeries scheduled. But had it happened during a weekday, this could have had large scale impacts across our region in terms of healthcare delivery. We also are a beautiful city. I hope if you have the opportunity to visit Seattle that you do. But we have a lot of tourists that are here in the summer, and we have people that are unfamiliar and unprepared for local hazards. And this is something that a lot of cities that have high tourist populations also experience. So, every city has things that make it uniquely vulnerable, and including the things that make us all vulnerable. And so one of the tools that we've talked about in the heat preparedness community is the development of a heat action plan that is locally tailored and specific. And the heat action plan combines an early warning system, so something that determines when we act, we have some sort of surveillance capacity and threshold for action, combined with public health intervention, so that describe what those actions are. Mariana mentioned in my introduction that I used to be an emergency manager in Baltimore, and we at the time had one of the first uh, extreme heat plans or heat action plans, and we called it our Code Red plan. And it was developed in the city following the 1995s, or in response to the 1995 Chicago heat wave that killed a number of people, and that also highlighted the role of social vulnerability in extreme heat outcomes. And so Baltimore City was at the forefront of this, and one of the first cities in the US to develop an extreme heat plan. And some work had been done a few years ago by White Newsom et al., looking at how cities and other communities across the United States were preparing for extreme heat. But there hadn't been work to explore this in several years. And so our team set out to understand how, if and how, cities across the United States were preparing for extreme heat. And so we conducted a survey of the most populous jurisdictions in the United States in between September of 2021 and January of 2022. We actually initially set out to do this work in, I guess it was February of 2020, right when COVID was impacting local jurisdictions. And we got, I think, maybe one response to our survey. And then we realized that our local health jurisdictions were not about to respond to us anytime soon. So we stood down for about 18 months before we restarted the survey in September of 2021. And so we published this work in BNC Public Health, and there's a QR code here, and happy to share this with anyone who is interested in reading the full article. It's open access, but I'll give you some of the highlights today. So we surveyed health and emergency management agencies in 99 US jurisdictions with populations over 200,000. We selected these folks both because of the unique vulnerabilities of cities and because of if we were to think that anyone was dedicating resources to extreme heat preparedness and response, we hypothesized that it would be jurisdictions with more resources dedicated to climate and disaster related work. And in the United States, at least, a lot of that funding and resource availability is situated in cities. So we thought that if anyone was prepared to respond to us, it would be cities. And so we wanted to start there. We distributed these surveys, as I mentioned, electronically from September 2021 to January of 2022. And we had a 97 question questionnaire that was informed by that prior work that I mentioned that had been done looking at extreme heat preparedness and response in both urban areas and other US jurisdictions, done by White Newsom et al. And other recent literature about extreme heat. So we had a response that was representative of most of the jurisdictions, most of the regions across the United States. So this is a map, for those of you who are unfamiliar, of the way in which the US federal government, the Department of Health and Human Services, divides the country into 10 generally geographically proximal regions. There's some exceptions to that. For example, Region 2, which includes New York, also includes Puerto Rico and the Virgin Islands. And there are several odd explanations for that, which we can debate for a long time, but we won't. And so these are generally geographically proximal, and we had a response from all of these regions except Region 8, which is the purple region represented in the middle of the country. And I believe Drexel is in Region 3. And you could see we had a 50% response rate among jurisdictions in this region. I should have said on the last slide, we chose to survey both emergency management agencies and local health jurisdictions in each of these cities, because we had heard that through some informal discussions with our colleagues at the National Association of County and City Health Officials and others, that a lot of the responsibility for extreme heat preparedness and response in US cities might not be housed in public health agencies, and that there are other actors, namely emergency management agencies, who have primary roles in the development of heat action plans and in heat preparedness and response. And so what we did is we sent an email with the emergency management and public health contact for each of these cities and asked them to coordinate a response based off of who in their local jurisdiction was responsible for extreme heat preparedness and response. So again, cities are not a monolith. This is not being done uniformly. There's no kind of prescribed way to do extreme heat preparedness and response, and it's happening in different agencies across our country, which I will share a bit more about in a minute. But so of the jurisdictions that responded, we had about 60.5% that had a heat action plan. And so a little over half of the responding jurisdictions reported having a heat action plan. Of the jurisdictions that had a heat action plan, about 100% of them, or almost 100% of them, I should say 95.7%, so all but one of the jurisdictions that had a heat action plan reported that they had cooling centers. We did have a methodological flaw in our survey, which we discovered at the point of analysis, which was that we unfortunately didn't ask the question of whether or not there were cooling centers among jurisdictions that did not have a heat action plan. So that is something that we don't have an answer to, unfortunately. So we asked across jurisdictions, what are you doing in terms of heat preparedness and response? And the only thing that we got 100% of our survey respondents, so I should have said earlier, we had 37 survey respondents of those 99 that we surveyed. Only 100% said that they were issuing communications. Everything else was less than 100% of these jurisdictions. So only 75% even had a definition of what we're talking about when we're talking about excessive heat. And that is very jurisdiction specific. I mentioned here in Seattle, we have very temperate climates. Extreme heat, where we can see increased health outcomes, can be in the low 80s. And I apologize that I can't convert to Celsius on the fly, but low 80s Fahrenheit is where we can start to see heat impacts. And so that's very different from somewhere like Arizona that has very high heat, and probably even somewhere very different from a city like Philadelphia that has hotter summers. Only 61.1% of jurisdictions were conducting surveillance related to extreme heat. So again, this goes across both emergency management agencies and public health. So looking for health impacts when there is extreme heat, it's only being done by less than 2/3 of the responding jurisdictions. We found that a little over half were providing extending sheltering for people experiencing homelessness. As we all know, most homeless serving shelters are open at night, when in theory is at least a little bit cooler. It's not necessarily true during some of these extreme heat events in urban heat island areas, but generally it's at least a little bit cooler at night. And so these folks are having to go back out into the extreme heat during the day in almost half of the jurisdictions that were, or at least relocate, that were responding to our survey. Only a little over half had any sort of provision for power outages in their plan. Only about half had any sort of plan for increasing access to fans or air conditioning. A little less than half had developed any sort of vulnerability map. and only about a third were conducting any sort of evaluation. So I, as a researcher and former practitioner, find that the lack of evaluation is particularly concerning. And we see this across different public health emergency preparedness and response activities across different hazards. We rarely focus on evaluating our strategies. And what that does in practice is it limits our ability to generate evidence-based practice and our ability to know if what we're doing works. And so we have the potential to keep investing in strategies and interventions that don't work. And so collectively, if I could have one takeaway from this entire talk, is the focus that we need to have on evaluation in order to figure out what we should be doing and be able to do it better. So I mentioned that we asked people if they had this heat action plan, and for most things, we didn't see very many differences. The two differences that I'll highlight in jurisdictions that reported having a heat action plan and did not have a heat action plan is this idea of defining an extreme heat event. So they have some sort of a definition of excessive heat. About 90% of jurisdictions with a heat action plan had that definition, whereas only about half without a heat action plan had that definition. And about a little over 75% of jurisdictions with a heat action plan reported conducting surveillance, whereas only about a third of those without heat action plans reported conducting surveillance. This makes sense, right? Because I mentioned on one of my earlier slides that part of a heat action plan is that early warning system coupled with the public health interventions. And that early warning system is really saying, okay, when there is a heat action, when there's a heat event of significance, that's when we want to start taking action. And defining a heat event of significance becomes important in terms of being able to do that. And so we're seeing more jurisdictions with heat action plans defining excessive heat and doing surveillance work, which is pretty important stuff. So we surveyed folks, and surveys have flaws. They're subject to response bias, both in terms of recall bias. So, we're relying on people to remember what's in their plans, to go look up the information. There's also social desirability bias in terms of not wanting to tell us as researchers that what folks think we might not want to hear. So we also looked at the plans themselves where we could, and we published this work in the American Journal of Public Health. And one of our survey questions asked for folks to provide plans. We also leveraged some additional plans that were given to a reporter from The Guardian as part of a Freedom of Information Act request, and was shared with us. And we ended up with 21 plans that we looked at. And just to note that our corresponding analysis of these 21 plans does corroborate some of the common activities that we saw in the survey, or that were reported in the survey, in that 100% of the plans that we looked at reported use of cooling centers, conducting surveillance, doing communication and outreach. And then there was this other piece about interagency and organizational coordination that we didn't look at in our survey, but that was in 100% of the plans that we looked at. So based off of our survey and our plan analysis, some of the recommendations that we have were to expand and tailor guidance, tools, and resources for extreme heat preparedness at the local level. So they're using templates or planning guidance can make sure that jurisdictions are thinking through at least all of the different dimensions of an extreme heat plan, and thinking about different strategies that they might choose to implement versus trying to come up with those organically. So much as we can provide jurisdictions with those types of tools, I think we can have some more success. And I have here in the image a heat action planning guide that was developed by this folks in Phoenix to support planning among neighborhoods. And then also providing peer-to-peer and technical assistance to support the development of heat action plans. I mentioned when I was in Baltimore, more than a decade ago that we were doing extreme heat preparedness and response work. And so there are some folks in US cities and across the world that have been doing this work for a while. And it's one thing for me as a researcher or for a federal agency to go and tell a city what to do. And we found that jurisdictions working together and learning from one another's experience can be really powerful, and providing forums and outlets for them to do that can support a lot of professional development and capacity in this space. So moving on to another key finding, I mentioned that 100% of jurisdictions, both with and without heat action plans, reported doing communications. This was corroborated in our plan analysis. But what we found was that the ways in which they were communicating with folks might not necessarily reach the people that they identified as most at risk. So the plans, so people in our survey reported that they had identified people with low income as high risk, people who were older adults, and people who are experiencing homelessness, people with pre-existing medical conditions, and children. So these are the top at-risk populations. And then we see that folks are using social media and news alerts and the internet and email to communicate with folks. So lots of technology dependent ways to communicate with people. And some folks might not have these technologies to access some of this information. I also mentioned earlier that we sent out our survey to both emergency management agencies and public health agencies because we had heard that these plans were not uniformly housed in public health agencies. And I wanted to highlight this other finding from our plan analysis. So going back to that analysis of those 21 plans, is that most of the plans that we looked at were actually led by emergency management agencies, and public health agencies sometimes had no role and sometimes had very limited roles. And so as we're thinking about how we can better align the risk communication work that jurisdictions are doing with the at-risk populations that they have identified, it strikes me that public health agencies that have really great expertise in public health and risk communication can bring a lot to that conversation and add a lot of value. And so engaging public health agencies in risk communication planning might be a very natural fit in terms of engaging them in extreme heat preparedness and response. I think the obvious thing here is to integrate active warning and communications approaches, including those that are not dependent on technology access. Of course, this requires a lot of resources and is likely why jurisdictions shy away from this. Extreme heat preparedness and response is often not a funded or specifically funded activity in the United States. There are some supplemental grant programs. There's also opportunities to integrate it into other all hazards planning, but it's not something that is often specifically resourced. And so doing this kind of work can be a labor of love and not necessarily one that is funded. And so how do you do active warning and communications when you don't have any money to do that? And so I have here something highlighted from New York City called the Be a Buddy program, which is really to have neighbors help neighbors and check in on your neighbors. I mean, this was such a huge thing that we promoted during COVID of going to check on your neighbor. You couldn't physically at that time, but for heat, this also makes a lot of sense. We know that social networks are so important for extreme heat outcomes, particularly among isolated older adults. And so this program tries to be a low resource way of reducing that isolation and having neighbors go check on neighbors to see if they're okay during extreme heat. So this last finding that I'll highlight from our survey is that cooling centers, while ubiquitous among jurisdictions with heat action plans, may be inaccessible to those that need them the most. And so, reflecting back to my time when I was an emergency manager in Baltimore, some of our cooling centers were at community centers, and some of them we even tried to encourage people to go to city facilities, including police jurisdictions. And so there are lots of people who might not be willing to go to certain cooling center locations, right? Because they can be scary to go to. They also need a way to get there. And so in our findings here, we had only 26.1% of jurisdictions had anything in their plans to provide transportations to cooling centers. Oftentimes you'll hear people do things ad hoc, like make buses or public transportation free on high heat days. But what we saw in our responses to our survey, again, among those that had these heat action plans, only about a quarter had any plan to provide transportation to cooling centers. Also, only less than half of these jurisdictions, or I should say, sorry, almost half of these jurisdictions only plan to open cooling centers during the day. And during these multi-day extreme heat events in cities, the urban heat island effect reduces the cooling capacity in nighttime. And so the temperatures don't necessarily go down at night in a way that is significant to promote healthy outcomes. And so, plans to keep these open overnight can support folks that either have jobs where they have to go, they might be working during the day and outside and be very hot and then have to return to a hot home environment, or even folks that just need that continuous round the clock cooling access. And so our recommendation here is to engage the community to identify opportunities to improve cooling center access and use. And there's been a number of studies that have looked at accessibility of cooling centers to heat vulnerable populations. And we even did one led by a now PhD student, Quinn Adams at Boston University, looking at where these things are located and who might have access to them. So there's been a lot of work in this space. And now I think there is a need to kind of make that research work that we've done in the academy more operational to some of the local jurisdictions to improve their planning. So some limitations of our survey, we had a small sample size. We had uneven geographical distribution of response. I mentioned we had no responses in that region 8 in the middle of the country. We had, even though we delayed our survey because of those initial COVID-19 impacts, we suspect that some of the limited engagement in the survey overall might have still been because while the public might have been less concerned about COVID-19, a lot of our public health and emergency management partners were still in full swing of the response or reeling from it and the burnout that came with that or is coming with that to this day. The timing of the survey was not during heat when it might not have been top of mind, and that should say response bias, not response biad, but the response bias of the survey, which we tried to at least correct for in some ways with our subsequent or concurrent plan analysis. We also partnered with the National Association of County and City Health Officials to conduct focus groups with local health jurisdictions, both inside and outside of urban areas, to understand barriers, facilitators, and needs of U.S. local health jurisdictions to engaging in heat preparedness and response. Our survey and our plan analysis told us what these jurisdictions were doing, but not necessarily why they were doing these things. And so we conducted 4 focus groups with about 17 professionals representing 12 US states with relatively good geographic reach, except in the your area and in kind of the eastern end of the country. What we found from these surveys was that extreme heat planning is influenced by local conditions, which makes a lot of sense, right? Regional and climatic differences. Maybe there's not a lot of extreme heat events that have occurred in a city, or there could be a lot. So places that are have a lot of extreme heat might not view it as a risk because they see it as something that is a regular occurrence and not something that needs special attention. Local priorities, local policy, and public risk perception of extreme heat. And then this idea of capability to tailor approaches for at-risk populations. So, we see this a lot in public health as to whether or not people adopt interventions, but this feeling of do I know how to do something better than maybe what the National Weather Service is putting out? Can I add value? Do I have capacity to add value based off of who is most at risk in my community? The availability of partnerships to public health agencies to do this work, or perceived availability of partnerships and agencies that might be willing to work with them, and agencies that might have resources and availability to do some of this work. Again, I'll go back to my time in Baltimore. In that example, the public health department at the time, at least, was the lead for some of the extreme heat preparedness and response work. Yet cooling centers, for example, were at facilities that were not owned or operated by the public health agency, right? I mentioned that some of them were at police departments, some of them were at school, or at least informally, they were at police departments. People were encouraged to go to police departments where they were air conditioned. Some of them were rec centers, which was operated by a completely different city agency. And so the health department needed those partnerships, right, to be able to do anything in this space, and it required those partnerships for the health department to be effective. And so a lot of the health departments in our survey talked about how they needed other agencies on board or other partners on board to really do anything. They could do some of the surveillance maybe, but they couldn't act on any of the interventions or some of the interventions without those partnerships. And then available resources, and this is an ongoing challenge in our chronically underfunded public health system, including staffing, syndromic surveillance capacity, access to relevant data about heat and health, sustainable funding versus ad hoc, event-specific grant programs or one-time opportunities. And then the ability to leverage existing resources during an event. This is an ongoing challenge in all of public health preparedness and response, about ability to move resources, have people that are funded on a specific grant stop what they're doing and start doing response on another event, is a very big administrative challenge that many health departments in our country face. Our focus groups are only about 17 people, so we wanted to be able to engage a group of different folks in some of this work, and an expanded group across the country. And so we hosted a workshop at the 2023 Preparedness Summit, which is sponsored by the National Association of County and City Health Officials, had 135 attendees who worked with us to develop responsive recommendations to some of the research findings that we had from our focus groups. And I have them here, and I'll read them aloud for sake of accessibility. But to strengthen trust by frequenting community events and increasing a local health jurisdiction's public visibility during blue sky periods, so during non-heat events. Leverage already trusted messengers when trust is a barrier to outreach. Communicate early and often when an extreme heat event is forecast. Ensure all communications are accessible by utilizing a variety of platforms, including low-tech options, and are translated into multiple languages spoken locally. Maintain critical relationships with partner agencies and organizations. Actively develop partnerships with organizations already serving at-risk populations within the jurisdiction. Coordinate with healthcare coalitions, which in the United States are groups of healthcare organizations that try to work together on preparedness and response, as we have a competitive healthcare system normally, that can provide support through information and resource sharing. Prepare a list of cooling center locations ahead of potential extreme heat events and work with cooling centers to ensure maximum accessibility, for example, extending business hours. Several jurisdictions would just encourage people to go to air-conditioned spaces versus hosting facilities themselves. And so those spaces are often dependent on the operator in terms of when they are open and accessible. And then finally, know the at-risk populations in your jurisdictions and consider any special accommodation they may require to take health promoting actions. So, again, this peer-to-peer learning and sharing is something that we have found particularly valuable and important. And we can see that in these 135 people that voluntarily showed up to one of our workshops. I think it was first thing in the morning, and we had a really enthusiastic group trying to develop some of these solutions. this work is currently under review for publication, and happy to make that accessible once it is available. So with that, I do want to have some time for questions and discussion. I want to acknowledge our collaborators, Kat Hartwell, who is a former research coordinator and is now working as the health advisor for the Climate and Health Equity Initiative at Public Health Seattle and King County. Juliet Randazza, Matthias Korkmacher, and Jesse Kelly were graduate students at the University of Washington. And then my colleagues, Jeremy Hess, Amruta Norris-Samra, Kate Weinberger, and Greg Wallenius at Boston University, and their trainees, Keith Spangler, Anthony Sun, Quinn Adams, and Chad Milano. And again, our work was supported by the Wellcome Trust, and we're very grateful for that support to advance this work. So thank you. This is my email address, and I welcome any questions or ongoing offline discussion, but I'll also stop sharing my screen now so we can chat here too. Thanks.
It's a question for Nicole here in the room, or I'm not sure if the chat will have.
Yeah, we have one in the chat. We can start with that. So it's from Sama. Yeah, he said, thanks for the presentation. Do you have a sense of how much of the 34% of cities that said they evaluated plans and outcomes and not just processes? For example, does the plan actually work in preventing heat-related illness?
I would venture to guess none. And this has to do with some of my experience as a practitioner, where a lot of the evaluative work that occurs in public health and emergency management, or public health emergency preparedness and emergency management, occurs in the context of what they refer to as after action reporting, which essentially is a large group discussion called a hot wash, where people come together after an event and talked about what worked and why, and then go on to write a report that tries to get at some root cause analysis of what worked and why in different domains. And so this has been criticized by people that write them and people that try to leverage them to understand evidence-based practice, because a lot of it is subjective. It's not outcome-based. Sometimes it doesn't even look at processes very well. And it is often scrubbed for political reasons, right? Because this becomes a document that could be subject to a Freedom of Information Act request or otherwise in the public domain. And it's very hard to identify a lot of criticisms, and it can be even more hard if those criticisms could be perceived to have led to negative outcomes in a community where cities have been held liable for making decisions that have harmed public health during these events. So, I think that the ways in which our practice-based partners are evaluating these events, and I think they would agree with me, do not necessarily lend themselves to looking at outcomes. They don't necessarily lend themselves to learning health systems, in that they can be very political, they can be very delayed, and they can be very subjective. So I think there's a lot of opportunity there, and a lot of opportunity for partnership with academics to do some of that work. I'll also just comment, and I don't want to be to kind of take this one question for the entire time, but after this event, we were called by our local public health agency, a number of us at the University of Washington School of Public Health, by our partners at Public Health Seattle and King County, and asked, can you help us identify how many people died, or what was the health impact of this? And we said, sure, but we need access to data to be able to do that. You have, your great, we call it Rhino or Essence data, which is a lot of emergency department visit data. We have, the health department has access to other data about hospitals. And if you can share that with us, we would be delighted to, do some analyses and help get you some of that information. And the data sharing delays that we experience made it so that we were able to do that. I showed Joan's paper that she published those were very delayed because of those data access initiatives. So what we found was there wasn't a lot of capability or capacity. There's capability at our health department. We have a very strong health department, but maybe not a lot of capacity to do that work within the public health agency. And we were willing and able to do it, but we couldn't get the data. And so this emphasis on data sharing partnerships, thinking about how academic health departments and academic partners can support public health agencies to do better evaluative work is, I think, something that we really need to all work towards.
Not on here.
Questions in the room? Comments or questions here? So, speaking on something that you say, because first, thank you so much. I learned so much. I wanted to. I have a couple of questions. One, referring to just what you say about what your colleagues from University of Washington asked you to do after some event, like how many people died. So in this, in a lot of the documents of the health action plan, are there clear definitions about how to count a death from, from this type of events, from the, let's say, heat waves? Because I mean, often as a researcher, like, well, is it because of, okay, dehydration, okay, that's very direct, but there are a lot of indirect and I wonder to what extent, people working, like the practitioners working on that and assessing the impact of some of these events take into account and clearly define what are deaths from an event.
I think that's a really great question, and I will couch this with, I am not an epidemiologist, but I will say that a lot of there's a number of different ways in which I think health departments are looking at health effects from extreme heat, including those that are specific to heat-related illness, and some definitions of ICD-10 codes related to heat-related illness, including some that you mentioned, dehydration, heat stroke, et cetera, that people will look at. And then, there's, I think, attributable mortality that is just things that people might not have captured as extreme heat related, that a doctor might not have put into an EMR or coded as a heat related illness, but that we're seeing extra deaths among people or extra hospital visits among people who are vulnerable for a variety of different reasons. And so some health departments I know are looking at things like injuries that might happen during extreme heat events because of things that change during extreme heat events. While some might be looking more narrowly at those heat-related illness specific things. And, I think we didn't ask about that specifically in our survey, but that's another thing that I think folks might benefit from some guidance on at health departments. What should they even be looking for during these events? Because I think if we limit it to heat-related illness, we're going to miss a lot. But what does the literature even say are potential health consequences if you can't do a full-on, excess death or excess morbidity analysis in real time?
There's another question here in the chat.
Yeah, this is from Katie Invick, one of our community engagement core leads. She asked about, based on your experience, and this is a follow-up to your first question. Based on your experience in Baltimore and now on the academia side, do you have any reflections or recommendations regarding the framing or formats that would be most useful to health and emergency officials when avoiding some of these challenges? Yeah,
I'm sorry, the formats of what?
Formats, framing
or
yeah.
So
Katie, you can clarify. I mean, you can unmute yourself and
framing research findings. Yeah.
You want to clarify the question.
Yeah, so this is in follow up to Osama's question and then your response, Nicole. Thank you for all of these thoughts. I'm wondering, just because we are in the process of trying to, have research findings regarding the impact of these events or of these extreme temperatures. And we're struggling with what is the best way to deliver those to city officials. So the question is, in follow-up to what you were describing, is sometimes the challenge of having the data, getting it to the right people, and then even an internal report maybe not being as candid or as specific or as critical as it would need to be useful. I'm wondering if you have any thoughts on what we can work on from our side in terms of doing a better job of packaging the findings that we hope to have for city officials so that they can both use them and kind of feel empowered by them rather than feeling criticized or attacked or challenged by them in a way that is not supportive or conducive to them doing work to respond to these events. Thanks. Sorry, I'm a bit sick.
Oh no, I hope you feel better. So I always lean on asking the question of asking them that question, what is valuable to them? I think, there's so in climate and health space in particular, I've been doing climate before it was cool. There's just so much work to be done. And if we can focus our efforts on work that has dual benefit to practitioners, the information that we generate from our research, right, adds to the body of knowledge, so adds to the science, but also can inform an operational need in a community, we can have immediate impact and we can have long-standing impact. And so that puts us in a great position. And so asking, I think the health officials that your work might have an effect on what information do they need to do their planning or response better, and then trying to figure out a way to either adapt the work that you're doing so that you can concurrently collect that information, right? Like maybe the epidemiological work that you're focusing on might have a different research question, but if you just add a secondary analysis, you can get them the information they need to do their plans. That can go a long way in terms of trust building and making your research more relevant. And so, I think there's partnership building, there's trust building that has to be done, but asking them what information do you need to do your job better, or to help your community prepare better, and then trying to be as creative and flexible as possible in your research process so that you might be able to adapt or expand in a way that doesn't cost you much, and it might not end up in your paper that you publish, right? But it can get that information to them in a way that helps them and makes them feel that you're on their team, because you are and you want to be. It can go just a tremendously long way. And I will also say that when practitioners interact with researchers and you ask them, like, how could research be valuable to you? That's like a really hard question to answer, right? Like, research is such a big thing. It might not be something that they've thought deeply about, but if you ask people questions about what problem do you need solved, or what information do you need in order to be able to solve that problem, those are questions that are more palatable, more interpretable, and that can get you to the same answer. And so those are the things that I always try to work with my partners. The questions that Public Health Seattle and King County were asking us weren't necessarily ones that, as framed, were going to lead to a high impact journal article, right? But we could have got them the answers to the questions that they needed, while also getting us kind of the academic token that we needed, or that we were interested in terms of advancing the science.
So, Nicole, I have another question for you. When you talk about that I wanted you to expand or help us a little bit understand a little bit more what you mean, or how to promote that. So you talk about interagency collaboration or peer-to-peer technical assistance. So how do when we have spoken to people in different places, public health departments or something, it seems to us that there's some disconnection between these different organizations, which you clearly demonstrate how that part of the finding of your work. So how do this how to promote, or how do interagency collaborations happen, and how do peer-to-peer technical support?
So I'll answer those questions separately. So just some other work we've done that's not what I presented today, but about climate and health public health agency engagement in climate and health work, one of the things that we found was that public health agencies talked about not having authority or resources to lead on climate and health initiatives. And so there wasn't anything in the law that said that they had to do anything or that they had permission to do anything, right? And all of these public health agencies are government agencies that have rules for what they are supposed to be doing. So there was nothing giving them any sort of authority to act on climate, and they didn't have any resources to be able to do it. So they were really dependent on other agencies engaging them for a particular function that they were authorized to do or that they had resources to do. And they hadn't thought very deeply about what they should be doing or what kind of value they could add to that conversation. And so I think there's been a lot more thought about how public health can add value to climate and health initiatives. And extreme heat is one that is very obvious. Risk communication planning, helping with surveillance, and helping to kind of define and frame that narrative of that we are essential partners in public health, and these are the things that we can really bring to the table. And having agencies be able to articulate that can make public health not just a nice to have, but a real critical partner in these conversations. And that's where I think that we as public health professionals need to be, because ultimately the effects are on people and that's what we care about. So I think there's a lot of, because of the disinvestment in public health and the disinvestment in climate and health, there hasn't been a lot of ability to articulate why public health is a value add, if not kind of the or a very central partner in this work. And so helping agencies be able to articulate that, I think can support resources and support their engagement in those partnerships that are necessary. The peer-to-peer stuff is, I think, a second question, and providing forums for folks to do that. Public health agencies, I think, are still really hard hit from the impacts of COVID in terms of burnout and workforce issues. And one of the things that we've heard from our partners at the National Association of County and City Health Officials is how public health agencies are really valuing opportunities to talk to one another and to their peers. And so we've had a lot of success in doing focus groups and doing the workshop that I talked about at the Preparedness Summit, bringing people together to not hear from me, Nicole, at the University of Washington, who is 10 years plus out from practice, right? It's from someone who is living and breathing that and experiencing similar challenges and coming up with innovative solutions somewhere else. And so I think fostering those opportunities for folks, and heck, that can even help them to develop that narrative of how public health is a critical partner, and help them be able to articulate that in their own jurisdiction. I think is great for the field and for advancing the work that we're all trying to do.
Great. Thank you very much. Yeah, I may follow up with you.
I would love that.
For our own work. Any other comment or question for Nicole? All right. Well, thank you very much, Nicole. Again, learn a lot, and it was wonderful.
Thank you so much, y'all, and I hope you have a wonderful day and holiday season.
Thank you, and everybody, thank you very much for joining us. And the next webinar is February 12th. We will be joined by Dr. Aina Roca Barceló from Doctors Without Borders. So stay tuned for receiving the information, and hope you can join us. Yeah. Bye, everyone. Thank you very much.
Thank you.
Thank you all.